So, Doctor, we have two acrylic models here. I know one of them is conventional, and then this one I believe is PML. So, do you want to tell our viewers a little bit about the conventional model versus the PML model, its benefits, its complications, its risk, and why you even developed this technique to begin with?
Yes. So thank you for asking that question. So the conventional technique is the one that we started doing in 2013, and we have a randomized clinical trial study called the INSIGHT study that was published in the Journal of Neurosurgery in 2016 by Dr. Pauly. So this technique goes from the outer portion of the ilium to the sacrum. Now, this technique works, but it's limited by the sacral foramen. So the holes that you're looking at here are where the nerves come out. So the nerves come out ventral in the front. So the way you place this implant is you have to be lateral to the sacral foramen. Because if you put it in and you knock out the brow, the lateral brow of the sacral foramen, it would hit that nerve and the patient would have severe leg pain. So you want to avoid violation of the lateral brow of the foramen. So the size of the implants are limited to, it varies from like 40 to like 55. Some people put bigger ones. But you also have this blood vessel called the superior gluteal artery. That vessel supplies the posterior SI joint. There's another vessel called the iliolumbar artery that supplies the anterior portion of the SI joint. So the branches of the SGA, which is what we call it SGA, when it gets hit by this implant, they can bleed a lot. And, I've seen it bleed a liter where you have to pack it and just wait for like 20 minutes to have it stop. And then you either continue or just abort the surgery. The other thing is when you put these implants in, these are wedges. So these are not screws. So when these things are in the patient for more than 6 months, if they're not fused, if you have what we call non-union, and you want to take it out, you have to take a chisel to chisel around the implant and take this implant out. Now, when you do that, you're going to have a big hole left after you take the implant out. So now you have to either pack it with bone graft and then have the patient no weight on this leg for 6 weeks. Because if you have them put weight on this leg with 3 big holes in it, this can break. The ilium can have a stress fracture. The sacrum can have a stress fracture. So the benefits of the lateral to medial is a lot because we have the INSIGHT study, which is the RCT study, and it's the one that the insurance and Medicare use to approve minimally invasive SI fusion as a technique. So that landmark study in 2016 changed the game for SI fusion. But the limitations are the bleeding, the non-union, and then the limitations by you cannot go and hit the nerve in the hole in the sacral foramen. The size of the implant is a problem, and they're partial weight bearing. So partial weight bearing means they can only put 50% of their weight on this leg for 6 weeks. And then the other limitation is when you do bilateral SI fusions, you literally have to come on this side to do this one side. Patient is laying down, face down, and then the surgeon has to go all around to the other side, and the X-ray machine has to go all the way to this side, and then you have to re-prep this side. The logistics takes about 20 minutes to restart the other side. When I did this for 12 years, I thought about what ways can we change the process of SI fusion by increasing safety, speed, and size of the incision, and also reproducibility. So can you reproduce this technique? Remember, we used to do what we call a S2 screw. An S2 screw goes in the trajectory of the PML, but it's not a fusion screw. It's just a screw that goes into the ilium, and it crosses the SI joint. So I thought if we do that same trajectory for an SI fusion, and we use a minimum of 2 screws, which is what we did in this case, we should have stability across the SI joint. So in this case, remember this one goes from outside the ilium to the sacrum. The sacrum is a very vascular bone, so it bleeds quite a bit because it's what we call cancellous bone. Cancellous bone is like spongy bone. Ilium is cortical bone, so it's very thick. Okay, so we decided, okay, if we make one incision in the sacrum typically at the level of the S2. So you have S1, S2, S3, S4 foramen, S5 nerve. If you make it at the S2 foramen, you can actually diverge the screws from one incision, 1 centimeter. Typically, I tell people it's the size of my finger, the incision. And then you can do divergent screws at a 45-degree angle into the iliac teardrop. Okay, so we use special devices like guide wires and parallel guides. And we did this and we tested it in the lab. And we were able to cut down the time of surgery by more than half. We cut down the time of surgery by half, cut down the incision to 1. The surgery is a very safe surgery because you avoid the vessel called the SGA because you're strictly in bone the whole way. So you avoid any bleeding complications. You're going away from the nerves, so the nerves are in the middle. So you're going away from the nerves, so you don't have to worry about nerve problems. And then you have no weight bearing restrictions, so patients can walk right away. They can drive in about a week. They can do. I have no restrictions except no squats and no running. But other than that, I've had patients. I did a patient on Wednesday. She drove to Dallas on Friday for a concert. So so when we started doing this, we saw that the outcomes were better. Patients with BMI over 30, the bigger patients, they've had faster recovery from this because when you're obese, the SI joint pain is not inflammatory. It's more size-based. So it's a non-inflammatory pain. So once you stabilize the SI, they get almost instant relief, about 50%. I've had patients that came to me after 2 weeks that said, Dr. Oh, I don't know what happened. I said, what do you mean? She goes, I don't hurt. She's like 350 pounds. I said, I know. I said, it's because your weight was the problem. It wasn't inflammation. You didn't do anything wrong with the SI, but the force and vectors across the SI joint was immense. So we did 2 screws. Now I do 3 screws because I feel like now with my experience, I've done over 1,000 of this, I can get 3 screws on each side, and it gives it more biomechanical stability. So we wrote a paper in the Journal of Clinical Spine Surgery published in August of 2025 introducing the single position SI fusion called the PML. We also did a video narration of the technique, about 6 minutes, also published in the Journal of Clinical Spine Surgery. Now that the awareness of PML is increasing, we're going to have a lot of doctors and surgeons switching slowly to PML just because it makes sense. It's a new innovation, safe, fast, reproducible. Patients love it. We'll have patients call in to this podcast at some point to give us testimonies. We have testimonials on Google. We have testimonials on our website, www.ogunsendemdspine.com. You can read some of the testimonials on there. We have a video of the PML technique on the website. So that's the difference between those two. And since I started doing the PML, I've had a significant improvement in patients' outcome in terms of pain. And I've done a lot of salvage PML fusion on patients that have existing lateral to medial that did not fuse. And we use the PML to salvage their fusion.
How'd that go?
Very well. Think about it. When you have the triangles and it doesn't fuse, you've already blocked all the path possible to put another screw. There's no other way. Mm-hmm. So PML is the only technique that, because it's going from medial to lateral, it actually bypasses those implants and you can put it, there's always the teardrop that comes down. There's always that portion that is the hardest bone in the pelvis that you can get your PML screw into it. Sometimes I'll get 1 PML screw and the patient feels amazingly better. So it doesn't take much.
Doesn't take much. Mm-mm. So you don't have to put more than 2 usually?
No, the FDA approval is 2. Mm-hmm. Depending on the size of the patient. If it's a small patient, 2 is enough. But if it's a big patient, BMI over 30, or if you have a big pelvis, there's some people that just have a very big pelvis and you have room to put 3. In patients that have osteoporosis, meaning softer bones, sometimes I've put 4.
Interesting.
Yeah, because you want more fixation points for those people. So, but the more you do, the more you get comfortable doing it. PML is a very easy surgery to do, but you have to get comfortable. You have to know your anatomy. For example, when I talk about PML, you have to understand that the innervation of the sacrum is from the dorsal portion of the S1 through S4. So there's nerves. The dorsal branches of the S1 through S4 supply the back. The ventral portion is supplied by the L5 through S2. So these nerves are the ones that the pain doctors will burn to reduce the SI pain in patients. Medicare stopped reimbursing the burning, so it's called neurotomy or RFAs. The Medicare stopped reimbursing the neurotomies, so now most likely most other insurance companies will follow Medicare. So now patients are down to they do the injection because you have to do an injection. So Blue Cross Blue Shield requires at least 2 injections into the SI joint, and they have to have about 75% improvement in pain. When they do those injections, it has to be done under fluoroscopy or CT scans. When they do those and they get better, before they had the option of just burning the nerve, now they really don't have that. They have the option of just doing injections or the SI fusion. The fear before was patients would say, "Oh, I don't want to have back surgery." And I always tell people, SI fusion is not back surgery. SI fusion is fusing the space between your spine and your hips. Completely different. There is no downside to SI fusion. I always tell people that because SI joint doesn't move. It moves about 2 to 4 millimeters total, front to back. So it's a very stiff joint. Now,
So all you're doing is just supporting it.
you're just supporting it. The pain that people get is because the SI joint is hypermobile. So now it's moving 6 to 8 millimeter as opposed to 2 to 4. So the ligaments are doing too much. So that's why women, when they have kids, they stretch those ligaments for the kid to be to push out. But then the ligament does not return to its normal state. So now you have a ligament that was 2 to 4. Now it's like 6 to 8. And they have another kid, it goes to 8 to 10. And then by the time you have 5 kids, it's really loose.
It never goes back.
Yes. So that's why women are prone to have this, especially with multiple children. So the target is when you see patients in my office and they come in and the first thing I ask them is, how many kids do you have? And they look at me like, I have 4. I said, okay. It's SI, especially when the MRI is normal. So yeah, we've come a long way with the PML. PML has only been approved now 2 years. I think we have many more years of understanding PML and teaching PML to go. So I'm excited.
Sweet, that's awesome. Who's the ideal candidate for PML?
Great question. So when PML has a couple of risk factors. So the main ones is, like I said, if you have a female, you have a high risk of developing SI joint dysfunction, just because of the birthing hips, the way they're made. Women with multiple births, pregnancy. So women that are pregnant, they have to expand the SI joint, and it hurts. Now, you don't do surgeries on pregnant women, but at least you can diagnose the SI dysfunction. You also have people that have had back surgeries. Very common. I'll say 30 to 40% of failed back surgery, what we call failed back surgery, people that have had back surgeries, that still hurt. And you can't see it on X-ray. They just hurt all the time. So those patients, we found out through the RCT study and all the other studies have come out that 40% of those are SI related. So if you go see a surgeon that doesn't do SI surgery, he's going to say there's nothing wrong with it.
How come?
Because he can't see the problem. And he doesn't fix SI. And he doesn't believe SI is a problem.
How many surgeons are fixing SI now? I know it's a fairly new technique.
Yeah.
Or fairly
I would say before, probably 10% of spine surgeons were doing it. I would say probably now we're up to like 40, 50%.
Okay, so it's growing.
It's growing. But there are still some people that don't believe it exists.
How come?
Just because they don't believe it exists. They're older. They've never found SI as a problem. But those are the same people that refer patients for spinal cord stimulators. So spinal cord stimulator is what we use for patients that have had failed surgeries and you don't know what to do. Mm-hmm. So you put this device in their spine that blocks pain fibers going to the brain. We call them dorsal column stimulators. So we put it in the thoracic spine. So any pain coming from above gets stopped right there.
Yeah. So it doesn't really go to the root problem.
No, it doesn't. You're masking the problem.
Yeah, you're masking it.
Yes, exactly right. So
which is worse.
It's worse and then you develop a tolerance to the machine. And then you have to keep increasing the amplitude. Yeah. Now you're really turning it all the way up to get pain relief.
Yeah.
And then it just gets to a point where you really can't go any further.
But the problem's still there.
It's still there. It's the SI. So where we were. I've told the story before. When I moved to the East Texas, there were four spinal cord stimulator companies in town: St. Jude's, Abbott, Medtronics, and another company. Because every surgeon was just putting in those stimulators for failed back.
So you're telling me there's people walking around with those stimulators that never got their problem solved?
Correct. Oh, absolutely.
Just mask the pain.
Yes,
That's ridiculous.
I've done many SI fusions in patients with existing spinal cord stimulator that I take out when I'm doing the SI fusion.
Oh, that's crazy.
Yeah, so they get the SI, they get the stimulator, but then they've reached the maximum amplitude they can go to turn it up, and they're miserable.
So what did they do after that?
So I take them out and put the SI fusion, and they get 90% relief.
But you're telling me they could have just done SI fusion from
Absolutely, they could have been just SI fusion. Now, I'm not saying SI fusion cures everybody, but if you've had back surgery, recently I went for a visit at a hospital, and one of the providers there was limping, a female. And I said, why are you limping? She goes, I had back surgery 18 months ago, and I had my stimulator placed 2 months ago. I said, why do you have a stimulator? She goes, I have this pain in my right side that goes to my groin, down the leg. I said, can I see your x-ray? And then she showed me an x-ray, and she has screws from L4 through S1. I look at her SI. The SI looks very dark. That means it's very arthritic. I said, ma'am, you have SI dysfunction. She said, what is that? I said, and I showed her my website. She said, I have all those symptoms. So she's been walking around with a stimulator and still hurting. So someone like that, if you went to another surgeon that doesn't do SI, what they will say is you probably have, your screws are probably too small or whatever. They go back in, take out all the screws you have, put new screws. So you're having a major back surgery as opposed to a 20-minute SI fusion, no restrictions after surgery.
Less risk.
Yeah, less risk, 1 centimeter incision. So I see them. In fact, I have patients that I would do surgeries on that have had back surgery before. And I tell them, I said, oh, this is your SI. It's going to take about 20 minutes. She goes, how is that possible? I've been suffering for 5 years. I said, it's your SI. I said, why don't we do this? Let's do an injection. Let's see how you feel. I said, even if it's for 3 days, you get relief. It's your SI. They come back and say, Dr. Al, I felt great. For 2 weeks, I could do everything. And then the pain came back. I said, are you ready to have it fixed? Absolutely. They book them for surgery. It's outpatient surgery. So you can come in, get the surgery, go home same day. And they come and see me in 2 weeks, and they are like 75% better. I've had patients driving from Louisiana that came to have SI fusion with me. And when I told the wife, I said, oh, your husband has SI pain. She goes, your diagnosis is too fast. That was quick. I said, I've done 2,000 SI fusions. I know exactly what's going on. So we did the injection. We did the surgery. He had like 90% relief. The other category of people that have SI pain is what we call transitional syndrome. They have an extra vertebrae, like they have a 6th lumbar vertebrae. So those people have an abnormal motion of the SI joint. So not everybody that has transitional anatomy, we call it Bartholdi syndrome. Not everybody that has Bartholdi syndrome has SI pain, but about 30% of patients that have Bartholdi syndrome develop SI pain. So when I see those people, I can classically say, they say, Doctor, they said there's nothing wrong with my x-ray. I said, there's absolutely something wrong with the x-ray. One side is fused, the other side is not fused. I can see it. This is classic for SI dysfunction. So the more you see these patients, even when I go to the airport, I went to the airport. I was in, where was I recently? I was in
Going to Georgia?
Atlanta.
Yeah.
Yeah. And I was just eating the bar, and there was this paramedic sitting next to me, talking to a friend, talking about her left hip hurts. She fell off a ladder when she was, doing her job 10 years ago. And ever since, she's had this pain in her hip. And it's worse when she sits for a long time and, but when she stands. So I asked her, I said, do you have pain that reaches down the leg? She goes, absolutely. I said, do you have pain when you sit and stand? Absolutely. So I said, have you ever heard of SI dysfunction? She goes, not really. She goes, she was told she has what we call IT band syndrome. I said, you don't have IT band syndrome, you have SI dysfunction. So she looked it up. She looked at all the symptoms, which, when they look at the symptoms, they say, oh my goodness, I have all this. Mm-hmm. I mean, all of them. And so she called her husband at the airport, they're in the military, and she said, I think I have SI dysfunction. So she made an appointment from the airport with her doctor, and her doctor doesn't do SI fusion. So she's going to have to find somebody. So I gave her my email. I said, hey, use me as a second opinion, but I'm pretty sure that's what you have. And you don't just rush to do SI fusion. You want to make sure that the MRI is normal. Like if you do an MRI and the lumbar spine shows a big disc that is herniated, I mean, that's what it is. You don't go out and fix an SI for that. You fix the disc herniation. But if you do an MRI and it's normal, and this patient is miserable, and they fit all the criteria, and then you push on the SI joint and they jump, then you're pretty sure it's your SI. And these patients are so thankful because even if you get rid of 50% of their pain that they've been having for 5 years, it's huge.
Yeah.
So it's definitely something that God has given me that nobody really thought about, the PML. People ask me, how did you come up with PML? I said, well, it's just kind of like, you think about it, you're like, well, if you can go from lateral to medial, you should be able to go from medial to lateral. You just have to find a safe trajectory, right? So we found a safe trajectory. You have you learn from your mistakes. Sometimes you put a screw in the spine, in the SI joint, it looks fantastic. You get a CT scan. The CT scan shows that the screw is slightly in the joint. You learn, okay, next time I'm going to put it this way. And by doing that, and it didn't cost any, it wasn't of any issue with safety to the patient. They were in adequate position, but to optimize the trajectory, you're learning from your stuff, right? So these patients were doing good, and you just keep honing down the skills. So now I can do this SI fusion stuff in 25 to 25 minutes, both sides. I've done a lot of my staff's parents. I've done some of my partners' wives that have SI pain, and they do amazingly well.
So for those who don't know what SI pain is exactly, or what SI dysfunction is, in the simplest of terms, how would you explain it to someone who's never heard of it or has been misdiagnosed or has gotten treatment or back surgery to mask the pain, but in reality, they never fixed the root cause? How would you explain it to them? How would you help them understand it? What is SI pain exactly?
Yes. So SI pain, it presents almost like you have sciatic nerve pain. Okay, so when patients come to see me, and I have this thing I'm going to show you guys, it has all the list of things that can happen. So this here, and I'm sure you can see very well, has all the checkpoints. I have this on my website. I have this as handouts, and it's a marker of the symptoms of SI pain. So I'm going to just read this out so you can see it. It says, do you experience lower back pain, sensation of extremity pain down the leg, numbness, tingling, weakness, pelvic and buttock pain, groin pain, which is common, about 15%, feeling of leg instability, so you're walking and you feel like your leg gives out on you, disturbed sleep patterns due to pain, disturbed sitting patterns, so when you sit for a long time, you have difficulty standing, and vice versa. The most classic one I see is sitting on one side of the butt cheek. Very common because you're taking the pressure of that SI joint. And then pain going from sitting to standing. Classic SI pain, SI dysfunction pain. And once you know that these are the things to look out for, you are able to diagnose the patients and recommend necessary MRIs or CT scan or X-rays. Basically, you got to get X-rays minimum.
So do you want to tell me a little bit about the time? I know you moved to East Texas, and that's where you spent most of your years practicing medicine.
Yeah, so when I was in Boston, I was doing my fellowship. One of the hospitals here in town, in Longview, Texas, called my residency program and said, "Hey, we're looking for a spine surgeon for a hospital. It's been difficult to find one." And I was already interviewing in Dallas at TBI, Texas Back Institute, and Baylor. So I interviewed at Texas Back Institute and Baylor. And so I was already coming to Dallas anyway for an interview. So I said, no problem. So I added an extra trip to go to Longview, Texas. So I interviewed at those two places in Dallas, and then I drove to Longview. Longview actually upgraded my ticket from economy to first class, coming in from Boston. So that was a good thing. And then when I got to Longview, they offered me a more guarantee than Dallas because it makes sense. It's more, it's when we say rural communities, not in a bad way, they offer more than cities, right? So my wife, so we decided, I said, okay, we're gonna stay, we'll take the job in Longview, stay there for about 2 years, and then move to Dallas or Houston. But after 2 years, I had set up my practice in such a way that it was doing well. My patient population was high. So I decided, you know what, let me give it another 2 years, and then another 2 years, and then 15 years went by, right? But the good thing about my stay in Longview was, building up my practice, I was able to establish the first dedicated spine surgery unit in the whole of East Texas. We had 8 beds dedicated to spine surgery after post-surgical. This was a dream of mine. So spoke to the hospital, and they looked at the numbers and they said, absolutely, we'll make that happen. So we had 8 beds. This was established in 2022. At the same time, I was growing my SI fusion practice. SI fusion became a big part of my practice. I would do maybe like 4 to 5 every week. And then we developed an inpatient rehab center also at the same hospital with about 40% dedicated to spine surgery. So every Thursday, I established the first multidisciplinary spine rounds in East Texas. So what does that mean? It means I do rounds at 8 o'clock in the morning with different parts of the clinical team. So we had a case management team, we had a physical therapy, occupational therapy, the nursing staff, the head of nursing, the CEO of the hospital actually ran it with us every Thursday. And the COO and the CNO, the Chief Nursing Officer Assistant. And we also had a patient care advocate, a pharmacy head. So it was like 10 people, sometimes 14, would go from room to room and see all the patients post-op. These patients loved it. They felt like they were like on cloud nine because they saw the whole clinical team that was taking care of them show up and run on them, and they could ask questions. This is the first time most of these people have ever met a CEO, so the fact that CEO was there was very comforting for them. And it's I remember one of the patients told the CEO, "Hey, the TVs are too small in the spine unit." Within like a month, we had 60-inch TVs in 8 rooms. So those were ways for us to do that, right? So patient suggestion, they will say something. Then I'll look at the CEO. We needed recliners for the spine unit. Boom, we got recliners for the spine unit. I had patients request to be on the spine unit because of the way the nurses were well trained. Even one of the nurses on the spine unit, her daughter had been to multiple doctors for her SI. She was 330 pounds, severe SI pain. She'd had her nerves burnt and everything. Her mom is like 150 pounds. So her mom said, "Doctor, I think I need your help." I said, "What do you mean?" She said, "My daughter is miserable. Her SI hurts. She hasn't worked in 6 months." I said, "What are her symptoms?" She told me. I said, "Yeah, I'm pretty sure it's a SI." So she convinced her daughter to come see me. Her daughter, of course, didn't know what an SI is. I said, I'm pretty sure it's your SI. I said, "What do you want to do?" She goes, "I've been miserable. I can't work." She has 3 children. So she met all the criteria for SI dysfunction. So she had an injection. She felt better for a while, and then the pain went away. The pain came back. So I did her SI fusion. I did 3 screws on both sides. And I said, so when I saw her post-op, I said, "How you doing?" She goes, I have pain. I still have pain. I said, "Okay, that's fine." I asked the mom, who's my friend. She's a nurse. I said, "How's she doing?" She goes, "Dr. L, we went to New Orleans, Mardi Gras. My daughter was jumping up and down during the parade, no pain. Like literally, she was taking a video of her daughter. And her daughter will say, afterwards, "Oh, Mom, I'm hurting." But then she was doing stuff that she could never do before, driving, jumping up and down. So she said, her mom is my friend. She goes, "Dr. O, thank you so much for doing this for my daughter." And so right now, her daughter has no pain medication.
Nice.
She went from Percocet and all these injections and burning the nerve to no pain medication. Now, she still takes other stuff for, blood pressure and stuff, but for the reason why she was taking narcotics is fixed. Yeah. So that's the thing about this. So we developed. So the amazing thing is she works on the spine unit, and she believed me enough to give me her daughter to fix, and I fixed her daughter. And then after that, one of the spine nurses came to me and said, "Dr. O, my back hurts." She's 51 years old, spine nurse. And I looked at her MRI and I said, "Yeah, you have a bad back." I said, "Your SI is messed up." I said, "But you also have lumbar pathology." I said, "So here's what we're going to do. We're going to fix your lumbar spine and your SI at the same time," which I do sometimes. So I fixed her lumbar spine with screws. I fixed her SI with screws. This lady can attest. She may even call into this program one day. She said, Dr. L, you have done amazing things for me. Like, she's back at work. She's a nurse. She can lift patients. She can push patients. Before, she couldn't do it. So those are very important testimonies, because she's a spine nurse. When she sees my patients after surgery, she tells them, I was in your shoes last year or whatever, and I'm telling you, you're going to do good.
Must be a crazy feeling.
Oh my
Especially
goodness.
helping the ones closest to you, and then
Yes.
when it's like extra validation that your technique is actually helping people.
It's amazing, because I would tell her, and she works at nighttime. So when I do the surgeries and the patients are like at night, the first day she goes in to see him, she goes, hi, my name is blah, blah. I had the same surgery you had, and I am pain free. It's amazing. It's a good testimony. I don't have to advertise. She does it for me.
Yeah.
In fact, I request her to take care of my patients because it makes sense. So yeah, those are the kind of things. If this SI fusion stuff didn't work, I can guarantee you, people will say, absolutely not, I'm not doing it. When a spine nurse that sees my outcomes is requesting you to fix her daughter, it's working.
Yeah, that's awesome.
Yeah. So the other thing I was going to say, one more before we
Yeah, sure.
the PML technique is something that is teachable to a variety of specialties. Okay, I always tell people that the PML technique is not limited to spine surgery. If you're a pain management physician and you want to understand PML, we can help you. If you're an interventional radiologist and you want to understand PML, we can definitely help you, because the PML is a unique area. It's not spine. It's in sense of, it's not just a spine surgeon that can fix it. It's multi-specialty, right? So if you feel comfortable with procedures, anatomy of the spine, or anatomy of the pelvis, you want to help your patients, you don't want to rely on spinal cord stimulators, we are in a position to show you how to get this done safely, fast, and reproducible outcomes. So that is the goal of my journey. And we talked about the book. I wrote a book called The Faith and Purpose, the PML story. We launched it on lulu.com. It's going to be available at Barnes & Noble's, Amazon. It's going to be available at Apple, Kobo.com. So these are platforms. So this book is called Faith and Purpose, PML Story. It chronicles my life from Africa to the PML, the advent of PML. And then it also talks about our journey going forward, trying to expose a lot of practitioners to the ease of the easy way to learn how to do PML surgeries. So that's our journey. Our next step in our journey. We'll talk more about that in the future, but we will definitely have a situation where practitioners all over the world can reach out to us. It doesn't matter what language restrictions you have, or not just restrictions, just in general, what part of the world you're in. The goal is to get you to understand what the PML story is, the PML surgery. We'll have it translated in as many languages as possible, so it's easy for you to understand. So we'll give you more information down the road. Stay tuned. Join us on the journey. It's going to be a long journey. We're going to be dedicated to teaching this. Just join us and let's enjoy the journey.
Thank you, Dr. O.
Thank you.